Good morning, everyone. Welcome to the webinar. This is Rebecca Bailey, and I will be your moderator for today. I'd like to welcome everybody to the January 2024 webinar. We are so pleased to start a new year, and we have some great speakers lined up this year. I hope that everybody can join us as they present some very impactful work in the area of mathematical modeling. We have just one housekeeping item today. Our speaker will be taking questions at the end of the webinar. You can ask him questions at any time during the webinar by entering them into the questions box on the GoToWebinar side panel. Our speaker today is Dr. Thomas Yankeelov. We asked Tom to speak today after seeing his work in oncology and modeling, and we thought his recent publication on personalized clinical trials would be of great interest to our audience. Tom received an MA in Applied Mathematics and an MS in Physics from Indiana University before completing the Ph.D. in Biomedical Engineering at SUNY at Stony Brook. He completed his postdoc at the Vanderbilt University Institute of Imaging Science and climbed to the ranks of full professor in 2010. He then joined the faculty at the University of Texas at Austin, go UT, in 2016, where he's now the Moncrief Chair of Computational Oncology and Professor of Biomedical Engineering, Diagnostic Medicine, and Oncology. He is the founding director of the Center for Computational Oncology and also serves as co-director for the Quantitative Oncology Research Program and Director of Cancer Imaging Research within the Livestrong Cancer Institute at UT Austin. Tom is an adjunct professor of imaging physics at MD Anderson Cancer Center as well. The overall goal of Dr. Yankeelov's research is to develop tumor forecasting methods by integrating advanced imaging technologies with predictive models of tumor growth to optimize therapy on a patient-specific basis. And with that, I'd like to give a very warm welcome to our speaker today. Welcome, Tom.
All right, great. Well, thanks so much for having me. Can you hear me okay? And you can see the screen?
Yes.
All right, very good. All right, so I'm going to talk today about clinical trials for patients who are not average, and I'm going to start a little bit in left field, but just please bear with me for a moment. So in the 1940s, the US Air Force was trying to build a seat to fit what they called the average fighter pilot. This was the first generation of fighter aircraft, and they there was all of these accidents, these wrecks that were happening, but the engineering seemed sound, and eventually they figured out that the pilots were terribly uncomfortable in the cockpit and they couldn't maneuver well enough. So they hired this recent graduate from Harvard University who had done his thesis on quantifying human anatomy. And so what they did is they measured 140 different dimensions on 4,000 pilots, things like hand size and fingertip to elbow, and all these kinds of different ratios. They measured them in 4,000 pilots. And then they decided to focus on the top 10 dimensions that they thought were going to be the most important, and they were going to look for the pilots who were within the average of these 10. So this is where I would have the first bit of audience participation, where I would ask you, the audience, how many of these 4,000 people, these 4,000 pilots, fit within the average of this 10-dimensional space? And I would pause and people would throw out different numbers. And then I would say, actually, first I'd say, of course, that the average here was defined as the mean plus or minus 30%. So this is a really liberal view of what average is, right? And of the 4,000 pilots, actually 0 fell within this 10-dimensional space. And so he had this quote, the guy who ran the study says, if you design the cockpit to fit the average pilot, you design it to fit no one. There really is no average person once you get beyond a certain number of dimensions here in a suitably complex study. So this brings us to what I, in my infinite wisdom, see as the fundamental issue with clinical trials. And that is clinical trials try to identify the intervention that works for the population average, but there really is no average person. This is actually a fascinating subject, and there's books written on the topic. But by finding the therapeutic regimen that works best for everyone, that works best for that average person that doesn't exist, you're really finding the therapeutic regimen that works best for no one. So statistical inference, of course, it's enormously powerful, but it does rely on properties of large populations that it can obscure conditions that are specific to the individual. So high consequence decisions, things like what to treat a patient who has been diagnosed with a particular cancer, they have to be based on more than just data analytics. This is going to be a reoccurring theme today. So, so we'll watch for this popping up here and there. So the question is, how do we do this, right? So this is how I see the next 35 or 40 minutes of your life going. I can give you a quick summary of some results from dynamic contrast enhanced MRI and diffusion weighted MRI. These are two measurements from imaging that are quite common nowadays. And we're going to use those to sort of calibrate or power some physics and biology based mathematical models. And then we'll talk about how those things can then power digital twins so that you can run patient specific clinical trials. So I hope that given that introduction, you're suitably captured and you just can't wait to go on. All right, so we'll start here at the beginning. So what we're looking at here, this is actually old news now. This is stuff we did more than a decade ago. So you're looking at here is a woman who has been diagnosed with an invasive ductal carcinoma, a locally advanced breast tumor. So it's confined to the breast and or axillary lymph nodes. And this is a DCE, a dynamic contrast enhanced MRI study that gets at things like blood flow and vessel permeability. And here's the tumor here. Chest wall is over here. This is the lungs. Nipple would be over here. And so this is a patient who pre-therapy has a large tumor and lots of yellow, green, and red voxels indicating high blood flow, high vessel perfusion. Then after just one cycle of therapy, really no change in the size of the tumor, but now there's a reduction in the number of yellow and red and green pixels. And you can contrast that with someone who had residual disease at the end of therapy. And you can see here from this point right here to this point over here. Can you guys see my arrow as I move it back and forth? Can you see the arrow?
Yes, they can.
Fantastic, great. So as we move from pre-therapy to post-therapy, you can see that there's been an increase in the number of yellow, green, and red pixels as we move from here to here. So that means the blood flow in this tumor has increased. And the whole goal of this study was to use this measurement of blood flow and vessel permeability to separate who was going to be able to achieve a pathological complete response versus those who had residual disease. And in this setting, for this locally advanced breast cancer, if a patient can achieve a pathological complete response at the end of this neoadjuvant therapy before surgery, then the 5-year survival is very high. It's essentially curative. Whereas if there's residual disease, there's a higher likelihood of distant metastases or recurrence and even death. So the whole goal here is to be able to predict as early as possible who's going to have a path CR and who's not, because if they're not, then you could potentially change their intervention and try to get them to path CR. So if we do the receiver operator characteristic analysis on the DCE MRI data, you get these numbers for sensitivity, specificity, and the area under the curve. So pretty good, but nothing to stop the presses about, but solid. There's a signal here that perhaps with refinement could be even better. So that's the dynamic contrast enhanced MRI study. Now there's the diffusion weighted MRI study. So this is the same set of patients, and now we're going to look at a diffusion weighted MRI, which looks at how water diffuses around. And so actually, I'll back up for a moment. So the metaphor here is if you have a water ball and water diffuses around with some sort of characteristic time constant, it'll go a certain distance per unit time. But if I start putting barriers inside that water ball, then water cannot diffuse as far per unit time. So you have that picture in your head and you go in vivo and you go into tissue. And healthy tissue has its characteristic architecture and water diffuses around with a characteristic time constant. But if there's a tumor growing in there and there's more cells per unit space, there's going to be more barriers to water diffusion per unit space, and water cannot diffuse as far per unit time. And people have sorted out how to measure water diffusion with a diffusion weighted MRI, and that's what this measurement is here. So pre-therapy, we have a measurement of what's called the apparent diffusion coefficient, the ADC. And the red pixels indicate that's the highest area of water diffusion, and that would be the areas with the lowest degree of cellularity. And the lower values, the blues and the yellows, that indicates the highest areas of cellularity, the areas that might have the greatest chance of malignancy. So that's pre-therapy, and then after just one cycle of therapy, you can see that in this particular tumor, there's a lot more red pixels here. which means the water diffusion constant has gone up, which means the cell density, the cellularity, cells per unit space has gone down. So the interpretation here is that this treatment is killing the tumor cells, as opposed to a non-responder down here, where there's been basically no change at all in the water diffusion from here to here. So when you do the area of the curve analysis and so forth, you're at 0.81. Now you can combine these measurements easily in the same patient. In fact, that's what's done for most breast studies nowadays. If you're familiar with the I-SPY trial that's been going on for about a decade now, they use these two measurements in trying to assess response. So if you combine those measures of perfusion, that was the dynamic contrast enhanced MRI stuff, with the cell density, that was the diffusion MRI stuff, then you can correctly predict who's going to achieve a path CR after one cycle of neoadjuvant therapy about 88% of the time. So that's pretty good. That's a retrospective study trying to separate people who had women who had complete response versus those who had residual disease, and that's pretty good. So we want to keep this number in our mind. Because these statistics are pretty good here, it gives us motivation for using these parameters, that is the perfusion and cell density, as inputs into a mechanism-based model. The whole goal here with building this mechanism-based model is we want to be able to predict how the tumor is going to grow in space and time. Because goodness, if you could really do that from early in the course of therapy, if you could predict how the tumor is going to grow in space and time, then you can go on the computer and you could simulate a whole range of therapeutic options and then select the one that has the highest probability of success. So that's where we're trying to get to by the end of this story here. So the metaphor that we always tell people is, just as satellites provide the data for weather forecasting, we try to use quantitative imaging data to provide the data for tumor forecasting. So just like if you have this is a global map of humidity. You can also get ones for pressure and temperatures and so forth, and these go into these system of equations from fluid dynamics called the Navier-Stokes equations. They go into your weather model to make a weather forecast. We're going to try to take these measurements of blood flow and cellularity to go into a tumor model and to make a tumor forecast. Of course, there's a whole host of other measurements we could make for imaging and otherwise, but for the time limitations today, we're just going to focus on these guys right here. So this is, if you get nothing else out of this presentation, and I understand that's entirely possible, I would encourage you to look at this paper. It's a perspective, it's easy to read, and it kind of tries to lay out a science of tumor forecasting, I think is what we called it, towards the science of tumor forecasting. Okay, so that's the background information. And I might pause here for 10 seconds and say, is there any questions about the measurements we're going to be using or what the goals are going forward? I'm looking in the questions in the chat box, and if I see anything, I will try to respond. Okay, well, I hope you're out there. If you have any questions at all, just put them in there and I'll do my best to answer them. All right, so if you open up chapter 1 of any book on mathematical biology, you're going to see exponential growth. And here's the picture. And I apologize if I'm insulting your intelligence with this. I also apologize if you see this and you start to get a little bit nauseous. So we'll try to thread the needle here. So what this means right here is n is the number of tumor cells at time t, and the left-hand side of this equation means the rate of change of the number of tumor cells with respect to time. And it's equal to how fast those tumor cells are proliferating, call that rate k, and the number of tumor cells that are present there. So you can solve this equation easily, and it looks like this in its exponential growth. The number of tumor cells at time t is equal to how many you started with, that's n sub 0, how many were there initially, and then times exponential growth. And you get this curve right here. And actually, this is what you see for cells in a petri dish. They will grow, tumor cells in a petri dish with plenty of glucose will grow exponentially. In fact, you even see this when you put a tumor on the hind limb of a mouse. It will grow exponentially for early time points. But at some point in the dish, there's going to be a limitation, a physical limitation, the walls of the dish. There's going to be competition for the nutrients. And similarly, for that hind limb in a mouse or for a tumor growing inside an organ, there's space limitations. So the next thing to do is to take our little exponential model here and tack on this logistic growth term here, where theta is the carrying capacity. So that's kind of the maximum number of cells as you can fit into whatever region of space you're looking at. And so you'll notice here, as this number n gets close to the carrying capacity, that is, as the tumor proliferates to the point where it's basically packing the system as much as it can pack, then n is close to theta. So that fraction becomes close to 1. 1 minus the number close to 1 is close to 0, and the rate of change dn by dt goes to 0, and you have this asymptotic approach to the carrying capacity. And in fact, that's what you see that up to first order with cells growing in a dish or a tumor growing on the hind limb of a mouse. So these models are fantastic for those kinds of simple situations, but they don't describe spatial variations in tumor growth. And this is where life starts to get a little bit more complicated. Now, if you want to describe how things are growing in both space and time, we have to move away from ordinary differential equations, which are these two guys, to partial differential equations. And so that's what this looks like. So that now we're looking at the rate of change of n with respect to time, and n can change in x, y, and z. This bit over here is our logistic growth that we see over here. And then now we have a diffusion term. So if we have one derivative in time and then two derivatives in space by this little upside triangle, that means the thing is growing out into space. So now we have a model that's describing logistic proliferation up to some carrying capacity, but it's also allowed to move out into space. Okay, I promise we're almost towards the end of the math part, and then we're going to start using it. So this is a repeat of the thing on the bottom of the last slide, nothing new there. The rate of change of tumor cells is due to how it's diffusing out into space and how it's proliferating. And we used this one initially, but all the tumors we were simulating were growing way bigger than what we actually saw in patients and in our animal models. And so then it occurred to us, these tumors don't just expand in a radially symmetric manner. So we coupled it to the mechanical properties of the surrounding tissues. There's a whole body of work here, led by Rakesh Jain from Massachusetts General Hospital over the last 30 years, goodness. And so we then extended this model to account for tissue mechanical properties, and that's what this is. So this is the same equation as up here, but now we're going to take the rate at which the tumor cells diffuse, and then we're going to exponentially damp it by this thing called the von Mises stress. And if you don't know what that is, don't worry about it. It's just a way to get a bulk average in some sense of all the stresses that those tumor cells are experiencing from the surrounding tissue. And then there's a mechanical equilibrium here that this is the divergence of the Cauchy stress tensor is proportional, that's the lambda, to how the tumor cell density changes, or how it's changing in space. So we can solve this differential equation. Once we get this sigma here, the Cauchy stress tensor, we can then convert it to this von Mises stress here, which then is going to exponentially damp how the tumor cells can move. And so now they're going to preferentially move in the direction with the least amount of stress, which intuitively makes sense. And then once we started doing that, our predictions for the tumors, the tumor volumes were really actually quite good. So this just says we're now describing how tumor cell diffusion D is damped by coupling it to tissue stiffness. Intuitively, it's one of those things that after we did it, we were like, well, of course we should have done that. All right, the last thing is this drug component right here. So here is our movement. This is how the tumor cells are moving, and this is the last equation, I promise. How the tumor cells are moving, then how they're proliferating through logistic growth, and then how they're responding to treatment here. And so what we're going to do is we're going to use that diffusion measurements from MRI, the apparent diffusion coefficients of how water's moving around to estimate N, the cell density. So whenever there's an N in this equation here, we're estimating that from our diffusion measurements from MRI. Then we're also going to estimate how the drug is delivered by our contrast enhanced MRI data. So remember, that was a measure of perfusion and blood flow and vessel permeability. So we're going to use that to estimate how the drug is getting delivered to tissues. And then the things we have to calibrate for are the proliferation and the carrying capacity, and then the efficacy for the drug. So if you've ever fit a line to a curve to data to like a scatter plot in Excel, you have your scatter plot of X versus Y, and you right click on the dots and it says fit curve, and you go to pick a line and it puts a line on top of there. We're going to do the same thing with this model to our imaging data. It's fairly more complex than what I just described with the thing in Excel, but it's the same idea. We have free parameters in here, the K and especially the alpha. We're going to take those guys and calibrate it to our imaging data on a patient-specific basis. So we need an image set of the contrast-enhanced MRI and the diffusion data before treatment, and then at some point during treatment. We prefer it to be as early as possible. And from those two time points, we take it and calibrate this model to calibrate the K and the alpha and the theta on a patient-specific basis, and then let it run forward in time to make a prediction. And that's what this is. All right. So we have here an estimate of overall cellularity. This is just a schematic. I'll show you real data in a moment. and it's going from here to here to here, okay? And so we're trying to predict how the cellularity is changing in space and time. This is a breast tumor. There's a breast right here. The breast is now, we're looking at a different angle. The nipple will be here, chest wall is up here. This is what's actually measured at 3 time points. We take our first 2 time points to calibrate this model, and then we predict it forward in time. So as I send this little video forward, there'll be a thing here that's estimating how the drug is being delivered through this term right here. And that's going to have a prediction for how it's affecting the spatial and temporal cellularity, and it's supposed to be matching down here. So let this go. Here's the drug coming in. Every time there's a big light up here, we get a hit to the drug, to the tumor. Every time this lights up here, there's a hit to the tumor. So let's see that again, because that took a long time to make, and we want to make it, show it twice. So again, here's our prediction. Here's what's measured. Here's coming up here how the drug is being delivered. Every time there's a big leap right here, that's a hit to the tumor. And there'll be one more hit down here. That's the tumor. So this is what the patient actually received. This is how the patient's tumor grew, and this is what our prediction is. So if we do this, let me pull this out here. This is a prediction for what the tumor size will be. That's the bluish there, and the red was observed for this particular patient. And this is all 139 patients right here, the measured cell counts versus the predicted, and you can see there is a really good correlation between the measured and predicted here. This is the concordance correlation coefficient, so it's like a Pearson correlation coefficient, but there's a penalty for it if you're off the line of unity. So it's a very conservative way to compare 2 measurements. It's actually a really handy a metric to use for comparing any 2 measurements. So this is a really strong comparison, prediction accuracy between measured and predicted cell counts and measured and predicted tumor volume change. And then if we go and do the ROC analysis for predicting who is going to be a responder and who's not going to be a responder, we're at 0.89. Now, if you've been following along, and I'm certain that all of you are on the very edge of your seats, I hope there's somebody out there, because I don't see anybody. So this is a bit awkward. So I hope that you are enjoying this, or at least not bored. But if you've been following along, you see the AUC here was 0.89, and before earlier, when I just showed you the 2 imaging techniques and the statistical separation, it was 0.88. And you could be thinking, Tom, you just dragged me through a ton of math to get an AUC that's 0.89, and that's really the same thing as the 0.88 where we just did a statistical separation. So that part is not really true. When we did the statistical separation, that was retrospective, grouping patients into responders and non-responders and seeing what the difference is between those 2 imaging metrics, the diffusion data for cellularity and the contrast enhanced data for perfusion. But we could not use that prospectively to predict how the individual patient was gonna respond. Here, not only can we predict prospectively how the patient's going to respond, we now have a mechanism-based model. That's the equation that I showed you on the top of the last slide there. We now have a way that can predict how the tumors are responding in time. And if we have confidence in it, then we can go on the computer and ask questions like, okay, this is how we gave the treatment now. What's the likelihood of response? Now, what if we gave the treatment swapped orders for drugs 1 and 2? Or instead of for drug 1, what if we gave it not all at once, but if we divided it up into 1 hit a week for 3 weeks, because some of these drugs are 3-week cycles. You can explore all of those things on the computer to come up with hypotheses for the best way to treat a patient. You can actually do these, straight away in an animal, but also there are multiple standards of care, right, for a patient with a particular drug type, tumor type. So you could explore on the computer the different standards of care for what might work best for Miss Jane Doe. All right. So we're getting pretty good at predicting the spatial and temporal development of these breast tumors, at least in the neoadjuvant setting. Does this nonsense generalize? We're using the visit 1 and visit 2 data from the I-SPY2 data. So this is a multi-site, a national study. The data we have is from 10 different sites, right? So every time you go multi-site, there's more introduction of noise and slight differences in how the data is acquired. So this is a real test to see if we can actually, if our modeling nonsense can work in these things. And the early indications are, there's like 200 patients in this data set, 212, I think, and we've gone through 52 of them. And so far, our mapping between the measured and the predicted is just about the same as it was before, maybe a hair worse. We'll see how this changes as we get up to 200, but it's similar there. These concordance correlation coefficients are still solid, and this is with patients for 10 different centers. So I'm now actually starting to actually believe that there's something to this. We've done this in many different trial settings. but it was always trials that we were either associated with directly or indirectly. But this one, the iSpy, we had nothing to do with this data. This is publicly available data that we just downloaded. We have similar results for brain cancer. This is what's observed 1 month post-radiation therapy. This is what was forecasted, and you can see this one maps really well for that one. So sometimes our predictions are spot on. Sometimes we're underestimating. Sometimes we're overestimating. But by and large, it's not that bad. And when you do the correlation between the measured and the modeled, it's still pretty good here. There might be a systematic underestimation in the prediction there. And we also have this going for prostate cancer. It's a similar story right here. So the idea here, the point I'm trying to make here, is that since these are mechanism-based models that capture important things about how tumors grow and develop in general, as long as you can make the measurement in the person, then you can use this nonsense to make a prediction. So it's generalizable, right? All right, maybe I should stop here again and see if there's any comments before we move into the home stretch here. Perhaps there's some cries of joy or shouts of misery. It's all the same to the torturer.
Actually, Tom, there is a couple of questions that you might want to answer.
Okay, I don't see them. Where do you have them?
I have them. I'll go ahead and read them.
Okay.
How are you converting your images into a spatial domain?
Okay, so the images are, of course, acquired spatially. So for example, for the contrast enhanced data, we have at each pixel location a measurement of blood flow, of tumor perfusion, and so those are that's how we it's an image where the spatial variation in the perfusion is already, each pixel has a value for perfusion in it, so it's already spatially mapped. So then our PDE, our partial differential equation that we calibrate to, is going to be calibrating for proliferation at each pixel location using the cellularity map from the diffusion MRI and the perfusion map from the DCE.
And could you tell us again what the alpha parameter in your model?
Oh yeah, sure. That's the treatment efficacy. So how good is the drug at killing the tumor cells in that particular patient? So it is implicitly capturing all of the mechanisms of actions, whether it's if it's a direct chemotherapy, or if it's a monoclonal antibody that latches onto a cell surface receptor and changes a whole slew of things intracellularly. It is implicitly capturing those with a bulk estimate of how it's killing the tumor cells.
Can you tell us what is the time interval between visits, and does that influence?
Right. So that's a great question, and we've done it in lots of cases. If we've designed the study, then we have some sense that we have some control over when that second imaging study should be. We've done it as early as after one cycle. It's pretty common to get one in the middle of a therapeutic regimen, or after 2 cycles, perhaps, is the one we've worked with a lot. So it's open to the design of the study. It doesn't have to be any one. There's pros and cons to it, right? The earlier you put it, the earlier you're going to get your prediction for how it's going to for how the patient's going to respond. You get that prediction earlier. But if you wait later, the dynamics of the tumor have evolved a little bit more, and so your calibration with your model is probably going to be a little bit more accurate. So your prediction might be a little bit more accurate. We actually have a whole theoretical study going about what's the optimal time point to a scan. It falls underneath the heading of this whole world called optimal experimental design. So we have a whole thing going on that, but I think our first presentation at a conference is next month. So it's just an abstract. We haven't come up with the definitive answers to that one yet.
And I'm going to take one last question before we go on with the talk. You show a single localized tumor. Many times there are multiples. Does your modeling integrate that?
Yeah, that's no problem, because remember, the data that's driving the modeling is imaging. So it captures the whole, in this case, the whole breast, the whole 3-dimensional structure of the breast. So if there's a primary tumor and little satellites, or if there's a tumor that starts and stops, for example, and then starts again, we'll pick that up as well. The place where we currently have the biggest problem is in trying to tackle metastases. If there's multiple metastases, like brain metastases, we can handle, but if there's multiple metastases throughout the body, you have to have imaging of those multiple metastases, and that typically, for full body imaging, you're typically looking at a nuclear method, typically PET, even more typically FDG PET. And so that is a good marker of, of glucose metabolism, but it doesn't tell you much about cell density or perfusion. So we're currently have projects where we're trying to adjust our models using FDG PET data, but that's much more exploratory at this point.
Okay, let's hold the rest for later. I think they'll apply for all the talk.
Okay, great. Okay, thanks. I hope this is of interest. All right. Okay, so I said it once before, but I'm going to say again, if you get nothing else out of this presentation, I would encourage you very much to look up this paper here. I had nothing to do with it. Karen Wilcox led it. She's the director of our Oden Institute for Computational Engineering Science here at UT Austin. And so she's an aeronautical engineer. And so her and her team have built this mathematical abstraction of what a digital twin is and its associated physical asset. So they're in aeronautics, and so they have assets. We have patients, so we don't typically refer to patients as an asset, but here we go. So there's 6 components. 3 of them live in the real world, and 3 of them are sort of their digital counterparts. So this is the things that correspond to the physical asset. These are the control inputs, the things you can do to the system, in-flight maneuvers, a maintenance or inspection, those kinds of things that you can do. There's the physical state, like the thickness or the crack length here on a wing or whatever. It's the physical state of the object you're looking at. Then there's the measurements you can make on the system, the observational data. So measured strain, inspection data, flight logs, which might be similar to like a radiologist or pathologist read of imaging or pathology data. So these are all the things that exist in some sense in the real world. Then there's the digital counterparts, the digital asset, the digital state. This is the geometry, the boundary conditions of your problem. There's the reward. This quantifies the overall performance of the asset twin system. So was the mission a success? Did the Amazon drone deliver your shoes properly with minimal fuel burn? And what are the maintenance and inspection costs associated with this? And then there's the quantities of interest, the stress and the strain, the remaining useful life on the wing, those kinds of things that you want to keep track of. So this is a really powerful framework to attack problems in oncology. And so here's how it might work for our breast cancer example. So here's a digital twin for predicting and optimizing treatment response. You have the physical state, call it S, and we're going to subscript it with I because you're going to be iterating on this, right? You don't just treat a patient once and then it'll just turn them loose. You take a patient, you treat them once, and then you make follow-up observations. So there's this back and forth between the digital twin and what exists in reality. So there's the physical state for us. This is anatomy and morphology, the mechanical properties, the physiological state. The mechanical properties have to do with the stresses and strains of the tissues. Physiological state might be the cellularity and the blood flow we've been talking about. There's all the observational data right here that I put in a bunch of imaging measures here because I grew up in imaging science, but you can imagine this could be histology, clinical data, whatever it is that you have in your model. Then there's the things you can do to the system. You can order more imaging studies, you can take a biopsy, you can change or adjust the treatment. These are all the things here in blue that you can do to your patient. Then there's the digital counterpart, the digital state. This is your finite element mesh, your boundary conditions, your computational domain. And inputs to the system can be, for example, treatment regimens. So I want to zoom in on this column over here. So this gets to the idea of trying to simulate on the computer different therapeutic regimens, right? Because everybody knows, back to that very first slide about there's no average patient, everybody knows that the therapeutic regimen you land on from phase 1, 2, and 3 clinical trials is not the perfect one for each individual patient. It's some bulk average, the best for the bulk average of the population that was studied. So in some cases, maybe it's true that just giving one bolus injection and having 20 days, having the cycle repeat 20 days later, maybe that is the best for some patients. Maybe it's better to do once a week for 3 weeks, or maybe the other extreme, which really isn't practical, but it is done in radiation oncology, is to do a small amount every day for 21 days. Or there could be combinations or things in between here. And there is not enough money or patients or resources to experimentally investigate all of those different possible ways to treat a patient. It gets even more complicated because most patients just don't get one. We've been focusing on triple negative breast cancer, which until very recently was 3 drugs. Now it's 4 drugs. So now you're just not trying to figure out what's the best way to give those 4 drugs. It's what's the order and timing of them. You can't experimentally figure that out. You cannot run enough clinical trials to sort that out. But if you have a mathematical model with mechanisms for the underlying biology and physics guiding the system, you can try that on a computer and sort out the best ways to then test prospectively. So here's our quantities of interest. We might have how the therapy is being distributed, how the shape of the tumor is changing, how the cell density is going down, and then there's our rewards. And for us, this is things like treatment efficacy and minimizing toxicity. And I want to spend just 30 seconds on this plot. So here's a plot of dose versus schedule, right? How much of the drug was given, and then what scheduling was being. So how much is the area underneath these blips here, and then the schedule is, all at once, or once every week, or once every day. And you can come up with metrics that are going to balance tumor efficacy and toxicity, and that's what this vertical axis is here. So you can go on the computer, once you have a model that you have confidence can capture the spatial and temporal changes of the tumor, you can go on the computer and you can try all combinations of dose and schedule, and you get this surface plot right here. And then you can look at it and say, well, this is the one that has the optimal regimen. And what we found is that most of the time, the optimal regimen is actually very far away from the standard of care. Sometimes it's very close to it, but most of the time it's far from it. And that's not really surprising, because there is no average patient. So that average dose you landed on is going to work well for some people, but which ones, right? And I'd also point out right now that this kind of analysis cannot be done with an AI big data approach, because in an AI and big data approach, you already have to have the data. Here, we don't, because we have a mechanism-based model that we've calibrated for the individual patient, and then we can predict for it all in all in all. To do this with an AI and big data approach, you already would have had to have that patient population and given all the possible doses and schedules to that patient population, from which you could then compare Miss Jane Doe. It's actually worse than that, because we're saying here that the individual is very important. So building this kind of surface up for a population is going to be entirely different for Miss Jane Doe. So the patient comes in with their physical state, you make your observational data, you build up your digital state, you track your quantities of interest and try to optimize your rewards, and then the whole thing repeats again. You go back to your control inputs. Maybe you need more data for imaging or biopsy, maybe you're going to adjust your treatment, and the whole thing shifts around. So this gets to the point I was trying to make. I wanted to zero in here about trying to pick one of multiple standards of care. That's what SOC stands for right here. So this is a surface plot for one patient. This is one of those plots that sometimes we show that it probably took us 8 years to make this plot, to get to the point where we could make this plot. So here, this is standard of care for triple-negative breast cancer, adriamycin, Cytoxan, and Taxol. Now an immunotherapy has been added, but when this study was done last year, that had not been quite rolled out yet. But this is what the patient actually received. This is the combination of Taxol and AC that they received. These little surface here is what we think the final tumor burden will be had we had given the different combinations of Taxol and AC. So everything that's below this grade plane right here, we predict is going to be a pathological complete response. And everything above it, we're going to predict is going to be residual disease. So here, what the patient actually received led to having residual tumor. But at least in theory, at least according to our mechanism-based model, there are 3 other standards of care that potentially could have gotten this patient to a pathological complete response. I say this and I still have shivers up my spine. This is a kind of a big deal. So without changing the total dose, just shortening or lengthening the duration of AC or paclitaxel, it changes the efficacy of the drug. And in this small study, there were 37 patients, 18 of whom had residual disease. They were non-PCR. And by doing this analysis, we were able to find standard of care therapeutic regimens for 8 of them that we would have predicted would get the patient to a path CR. Okay, so that's a take-home message. And you can't do this with an AI and big data approach, because you can't make this plot prospectively. You have to have already acquired all of the data to have done this. And it's worse than that. You have to have acquired all of this data for an individual patient, which can't be done, of course, because you can't make all these different combinations of treatment for a patient. You have to have a mechanism-based model. All right, so we've developed a framework for model development, calibration, and selection to do this for mice, to try to test this prospectively for HER2-positive breast cancer. So the mice received trastuzumab and doxorubicin. We used a digital twin for the mouse. So we built this model, and we could use it to recapitulate how the tumor is growing in space and time through something called optimal control theory edit that lets us find the optimal, at least in theory, therapeutic regimen. And it can do 2 things. We can say, let's get greater and earlier tumor control. That's this one right here. So this experiment had 6 different arms. The best therapeutic response is this, I don't know what this is, magenta, this magenta curve right here. So we took our model and the patient's and the mouse-specific digital twin and did optimal control theory and came up with a different therapeutic regimen that we predicted would be able to get the mouse to this response earlier and sustain it longer. So that's one thing you can do. The other thing is, let's say we're happy with this level of tumor control given by the magenta line right here, but we want to use half the chemotherapy dose. That's what this is. So you can see this green line is mapping pretty good, the magenta one, and it's only using, almost whatever this is, 58% less of the total doxorubicin dose. So these are readily testable hypotheses that we can go and do in a mouse to lend credence to this idea of trying to use mathematics to identify an optimal therapeutic regimen. And so we did this. And so this is an email from last August from our collaborator, Anna Ceresi at University of Alabama. And she said, "Hi, Tom and Ernesto, my friend and colleague who's working on this with me." She said, optimal control theory, optimal dosing with 56% docs as opposed to the 100% docs demonstrate a 43% complete response, with the traditional combo theory demonstrating only a 29% complete response with 100% docs. They're using 100% of the dose. Then she notes, importantly, probably not enough mice to be statistically significant. We're going to inject more mice and add to this, and perhaps to see if we can do a second mouse model. And that study, we're waiting any day for the results of this. We have a bi-weekly meeting, and we could know if this significance holds up with a larger group by the end of this month or next month. And this is really, we're all holding our breath, right? Because this would be, to the best of my knowledge, the first time people use a mathematical model to compute what an optimal therapeutic regimen should be, and then compared it to the standard way of doing it to see if it outperformed it. This would be a nice result, I think. Okay, so I see it's 11:41. So are these ridiculous ideas? Can we ever get them to the clinic? So we can look to the I-SPY study. This is an adaptive clinical trial to increase trial efficiency by minimizing the number of patients and time required to evaluate a new therapy. So what they do is they had, I think it was 10 different arms, 10 different therapeutic arms. And a patient presents with some set of biomarkers, and based on those biomarkers, they get put on one of these 10 different trials. And they see, then the patient is assessed for how they're done. And as you get more and more patients on each one of these arms, when the new patient comes in, you look at their biomarkers, and the patients who had similar biomarkers who did well on one arm, there's more likelihood of them being randomized to that trial. So you're updating as time goes on, the patient's getting better and better care. We want to do that for the individual rather than the population. So here's the I-SPY 2 trial. A new patient comes in, they have some biomarkers, they're randomized to either the experimental or control arm. You look at their patient outcome by looking at either pathological complete response or residual cancer burden, whatever. And then based on how they came, how they did on their treatment arm, you update the predictive probability so that next time somebody who comes in with those same biomarkers has a higher probability of being assigned to the arm that works the best for those biomarkers. And then you do this enough, at some point you're gonna either eliminate the arm because it's not working, or you're gonna graduate it for FDA approval because it's working better than standard of care. So patient characteristics and outcomes are used to update how future patients are assigned study arms. And this adaptive design seeks to move patients from arms less likely to help them to arms more likely to help them, and do so as soon as possible in the life of the trial. We want to do this. We want to seek to develop methods that accomplish this for the individual through prediction rather than the population through assessment. So this I-SPY provides sort of a framework for how to do this for the population, and it's extremely successful. It's actually the one that led to the inclusion of pembrolizumab for triple-negative breast cancer. So it's a very successful design. Again, I-SPY seeks to assess early in therapy which population would benefit. We want to predict early in therapy which individual would benefit. So here's the point. Actually, I'm going to pause here. Before we get to that, I'm going to give you a quick overview of things we didn't talk about, because I didn't want to give you the idea that this is the only thing our lab is doing. I wanted to just sort of throw out one slide of things. We have a range of clinical projects going. We're trying to extend these techniques to sarcoma and cervical cancer, in addition to glioma and prostate cancer. We're trying to also predict the distribution and treatment of radio-labeled liposomes for intracranially injected, intracranially directed treatment for brain cancer. There's a host of preclinical projects where we try to develop these techniques and get them ready for clinical projects. So we have these mechanism-based ordinary differential equations linked to time-resolved microscopy data, In this setting, you can get a ton of data in a really short amount of time, trying to account for hypoxia, MRI-based hypoxia measurements to update our radiation treatment models, and of course, working hard to include the effects of immunotherapy. And then we have these projects that nobody thinks is sexy, but kind of have to be done to make progress. How do you build and select models? And are you sure they're identifiable? Meaning, can you invert them to get the model parameters that you care about? For us, what I've talked today, the model parameters we care about are the proliferation and the drug efficacy term. How far into the future can you predict given certain data limitations? And then we're trying to balance treatment efficacy and toxicity via these mathematical tools called null clients. So those are all things going on in the lab. So the point of the stuff that I talked about today, I promise I had one, was that if you want to design something that is useful for the individual patient, you got to rely on their individual characteristics because they are unique. So digital twins now exist and are practical for predicting and recursively guiding and even optimizing interventions on a patient-specific basis. I no longer think that this is a technical limitation. It's a logistical limitation of trying to get this into the clinic. You know, how do you actually present the predictions of a digital twin to a clinician and their patient? You know, this is uncharted territory. How do we deploy it in a practical manner? I would say that this effort to sort of mathematize oncology is inevitable. If you look at the history of science, once we mathematize something, we get pretty good at it pretty quickly. And this has already happened in cardiology. There's even a company with a product, HeartFlow. You might look them up. It's really interesting. Cardiology is probably 10 years ahead of where we are in oncology for doing this, but this is going to happen. I don't know if our lab will be the ones who push us over the finish line. I mean, probably not, right? But we like to think that we're part of the push. But this is going to happen. Here's a picture of the lab and all the people who did all the work. I, of course, just sit in the corner in the fetal position crying about funding and make sure that these people get paid and so forth. We always thank the patients who participate in our studies. And thank you very much for your time and attention. If you're interested, I'm happy to try to answer any questions. Thank you for the opportunity.
Thank you, everyone. And just a reminder, you can enter the questions into the questions box on your side panel. I'm going to go ahead and start reading some of these questions. On slide 18, there seems to be a bias at the higher volume changes. Do you know why?
Slide 18, there's a bias at the higher volume changes. I'm going to have to scroll back because almost there. Slide 18, a bias at the higher
Volume.
Oh, okay. No, I don't know that. This calls for doing a bland Altman analysis so we can see if our error is a function of size of the tumor, size of the measurement. Thanks for pointing that out. I'll have to look at that. Yeah, the only thing that struck me about that is that this is there's just a few number of patients out here at the larger tumor values. Most of them are down here, but definitely need to look into that. So thanks for pointing that out.
What is the potential and scalability of this approach, in your opinion, with respect to the number of patients?
Yeah, that's a great question. So for about the last 18 months, we've been slowly looking to make this into a product. So we've submitted 3 patents, we've copyrighted the code base, we've talked to a bunch of people about how this would play out, and the pipeline that we want to implement is very similar to what HeartFlow does. And so HeartFlow takes CT images of the chest and they're uploaded straight from radiology to the cloud, where they do their analysis based on fluid mechanics to see whether or not a patient needs to have a stent placed, and if they do, where should it be placed. So we envision a similar idea. I'm going to blank this out in case it's distracting. We plan on doing a similar thing where these images are acquired, and then on the software right there, after an image set is acquired for every day in the hospital, you click a box that sends it to the hospital's PACS. We could put another button in there that would send it to the cloud, where we would do our analysis and send back a prediction for the likelihood of response given the current course of therapy and the patient's changes thus far. So scalable, I think I think it'll be easily scalable so long as we can find an angel investor to help us pay for it. It'll cost about $150K to put it in place on the cloud. We have a detailed plan how to do that. So I think scalability is tractable for sure.
So in the past decade, Growing evidence suggests the significant role of the patient's immune system in their response to therapy. Your model lacks a term for immune interactions. Could the variability in your model implicitly capture this effect or be adapted?
Yeah, so that's another great question, and it is something that we worry about a lot. All the drug effects, regardless of what they are implicitly captured in that efficacy parameter. So whether it's ramping up the immune system, or if it's a broad spectrum chemotherapy that's like an intercalating agent, that'll be captured by that term, by that alpha parameter. That's unsatisfying because you want to kind of know, you want to explicitly incorporate the effects of an immunotherapy or a targeted antibody, Herceptin, or for example. So we are working hard to try to extend this to include the effects of immunotherapy. Currently, those projects are in the preclinical setting because we're trying to figure out what data types we need and what's the simplest model we can use. We always try very hard to use the most parsimonious model. Following Einstein's, everything should be as complicated as necessary, but no more complicated. So when we extend the model to include the effects of immunotherapy explicitly, then there's more parameters in there. And so we want to figure out ways to measure those things before we try to put it into the clinic. But we have access to data that will let us do this as long as we can figure out the proper way to mathematize it. So to answer your question, you're correct. The effects of immunotherapy or any other drug are just implicitly captured by that alpha parameter. And we're working hard to peel away the next layer of the onion to explicitly incorporate the effects of immunotherapy.
For a patient and in clinical practice, this would require online analysis and quality checks. What are your ideas to enable such approach?
Yeah, so we're kind of lucky in the sense of the quality, the QA/QC on the data side, right? Because the measurements that we're using are available on every MR scanner in the world and are done on a big chunk of the breast scans already, on all of the MRI scans, and on most of the prostate scans. Those are the 3 disease sites we're focusing on first. So every MR scanner in the world has to, or at least here in the States, and I'm sure there's similar governing bodies around the world, but they have to be accredited by the American College of Radiologists. And there's some QA/QC tests that are done daily, some that are done weekly, some that are done quarterly. So we've actually done, one of our studies was done in the community-based care setting, not a large research-oriented medical center. We did it at a community center at 3 different hospitals, and we took our measurements around, implemented them on the scanner there. It did phantom studies, did healthy human studies, and then got all the data back from them and put them into our model, and our predictive accuracy was the same as it was for something done at MD Anderson, for example. So on the data side of it, the data acquisition side of it, we feel really confident about that. The predictive ability of it, when we go to the model calibration and the prediction forward, we have error bounds on what the tumor will be. It'll be this size plus or minus this amount. The probability of success with this treatment is this percentage plus or minus this percent. So we have error bounds on those things, and we're constantly working to make them tighter. I don't know if that answers your question, but those are the 2 main things that we are concerned about: the data acquisition, which we actually feel pretty good about, and then the model calibration, which is the tricky part. But there's all sorts of numerical techniques that we can use to check that at each stage of the modeling process. Yeah, I don't know if that's a good enough answer, but that's what I got right now.
How can treatment modification due to toxicity associated with simulated alternative dose and regimen affect the model predictions?
Right, so I didn't go into that just given the time, and I thought if I put more equations, I'd lose more people, right? They say every time you put an equation on, you lose half your audience. So I don't think that's happened. We were at we peaked at like 98 attendees, and we're down to 82. So I hope it wasn't too bad. But so that you'd have another equation in there describing the effects of the drug on healthy tissue. So for example, doxorubicin, adriamycin, is known to affect cardiac tissue, and also I can't remember the cell type that in the brain where it's affected as well. So we have another equation that describes the effect of these drugs on those healthy cells. And so you now have to balance, if the number of cardiac cells that are injured passes some threshold, you're going to have cardiac damage. And so you have to make sure that your dose over time doesn't go above this threshold. So we have another differential equation that describes the rate of effect on these cardiac cells And how you adjust your treatment to try to kill off the tumor has to be contained by not going above this threshold over here. So it's now you're optimizing for two things. So that's how it's done.
Have you tried to include the dynamics of some intracellular pathways or cell interactions to improve the
Yeah.
accuracy of your predictions?
Right. So this is a great question, and we work on this a lot, but it's never made it really past the theory and preclinical stage. What you're talking about, I think, is what is building a multi-scale model. You know, we're sort of working at the tissue scale here with these measurements, and then you want to link that to a cell scale or intracellular scale model. And so there are definite ways, and we've done this. You know, we've done theoretical studies on this and published in mathematical modeling journals, where we link the cell scale or intracellular signaling to what's happening at the cell or tissue scale. And you can do that, and it gives you more insights to, for example, what the effects of the immunotherapy are, or what the effects of the targeted antibody is. And that's great because that can help you potentially refine the best way to give these drugs, and the order and timing and so forth. But the problem is when you go in vivo to try it on a patient, there's so many parameters that you don't have access to. So what we've just started brainstorming about is try to frame this numerically or mathematically so that the parameters that you get at the intracellular scale have to lead to results that are consistent with what's observed at the tissue scale. So that's how we're trying to frame this problem now. So it at least constrained the range of parameters that you could get for those intracellular signaling models. That's perhaps that's oversharing because we haven't published on that or written that out. We haven't. So that's what we're trying to work on. Yeah.
So treatments can put evolutionary pressure on tumors. The order in which you treat affects response. Can you predict the effects of changing the order of therapies if not all the different orders have been clinically studied?
Yeah, so we have done that so that the mouse study that I probably went through too fast. I was trying to show where we actually used a digital twin with optimal control theory to figure out what the best therapeutic dose was, and then I referred to my colleague Anna at UAB, who's doing the study going forward. That one did look at changing the order and timing of dox and Herceptin, so the chemotherapy and the targeted antibody. So were able to come up with an optimal way to order them and the spacing between them. And that's the study that we're holding our breath on to see if the second round of studies matches what we saw in the first round of studies. So we've done that in the preclinical setting. There was one other component to that question. Can you repeat it? I'm sorry.
So the order in which you treat affects response. Can you predict the effects of change in the order if not all the orders have been studied?
Yeah. If not all the orders have been studied within limits. We really want to know what the drugs do by themselves, and then in some combination. But it doesn't. You don't have to have explored all the orders and timings to come up with the best one. You just need to have sampled that space to some small extent.
Have you explored requirements for regulatory approval in the U.S. or abroad?
So we have, but I don't know the answers to these questions. I try to learn more about this, but I have a guy I work with very closely in tech transfer here at UT Austin, and he's the person who knows all of those things because we talk about these things, and he's very concerned. They hired an external firm to go through these things and come up with what the potential market would be and what the pathway to FDA approval would be. And then I'm so sorry this is terrible. When they explain to me, I just see a lot of lawyer speak and a lot of words. And I have to get better at this because I have to study this, but I don't have good answers for that. I'm sorry. My buddy Ruben would be the one to ask about that. So I'm sorry.
I'm going to ask one last question, and I will forward all of the questions that we've gotten on, because there's a whole slew that we haven't been able to address in the time. But okay. One question is, could you see these 3D simulations helping with a QSP platform for drug testing and development?
Oh, so yes, that is something that QSP, quantitative systems pharmacology, I think is what we're getting at here. So that is very attractive. We have had conversation with pharmaceutical companies as using this and in the drug development pipeline and trying to pair therapeutic regimens with particular disease subtypes during development. So that's something that's very exciting. Actually, it's even easier to do it in the preclinical setting because we have access to so much better data and so more frequently sampled. So that's of great interest. And so whoever said that, if you wanted to talk more about that, please shoot me a note.
Great. Well, we are out of time. I wanted to say thank you for all of our audience attendees, and thank you to Tom for a really interesting and absolutely fascinating webinar. We do have a bunch of questions that we have a lot of questions that we don't have time to address. I'll go ahead and send those on to Tom, and he can address them as needed. Thank you, everyone. I hope everybody has a great day, and I hope to see you again at a future webinar.
All right. Thanks so much. Thanks for the opportunity, everybody. Take care.
Thank you. Bye.
Bye-bye.